So let's run through screening a patient for suspected keratoconus or for monitoring for keratoconus. So in this case, we've got a patient and we have effectively no real indication at this stage that they're going to become keratoconic. So we've got a normal cornea. We can see that the metrics on the cornea, so their SIM-K value is pretty average at 777 by 771. And the disease indices, so we've got these 3 traffic light systems with the Medmont. Most topographers will give you a similar traffic light system. We've got effectively amber and we've got green to green. Now these are very sensitive. It's very common to have these being amber or even red in healthy cornea. What's important is these indices change significantly if the cornea changes. So it's not necessarily them being amber or green, it's if there's any change. And when we look at the corneal profile in tangential, again we've got a fixed scale here, so we can see that the cornea is falling in the middle of this scale. If we then go to a normalized scale, so we're tailoring the scale in to see the cornea, we can see that there's a little bit of inferior displacement. It's pretty spherical. You can see that the contours are pretty spherical. So this is why the IS, which stands for inferior steep index, so the power of the cornea in the inferior compared to the power of the cornea in the superior hemispheres is pretty similar, but you can see why, because we've got an inferiorly displaced cornea. That's normal. So at this stage, we're not concerned about any keratoconus. The other metric that's very useful is the K max value. So what is the very steepest point on this cornea? And if we do this in axial is going to dilute down any very small changes, so it's less sensitive. But in axial, we can see that we've got 43.86 diopters. If we were to look at that in millimeters, so let's go to axial curvature. So we've got the scale to millimeters. You can see that's 7.70. So K's were 777, K max is 770. So the Medmont will automatically give you the K max value when you do a normalized scale. If we look at this patient's eye at the next appointment, so 18 months later, you can see that we've got a slightly different pattern. You can see that there's now more distortion we've got within the contours, and the traffic light system has changed significantly. We've actually now got a green IS value, but you can see the SAI and the SRI. Just to explain these values, so if we look at the slide, you can see the inferior steep is the power of the cornea at the top to the bottom. The SAI is the power in the quadrants, and then the SRI is the power around the circular pupil zone. So they all pick up keratoconus differently depending on the pattern of keratoconus that we've got. So going back to this patient, again, this is a 13-year-old patient. This is now a significant change from the previous exam, so this would now be wanting to be monitored on a 6-monthly basis. Let's have a look at the next exam. Now this patient was pre-cross-linking, so this was not 6 months later, this was a year later. We can now see that there's red traffic light systems in the top 2. And also if we look at the K max value, the K max value has gone from 740 at the second exam, and it was 747, and the exam before that it was 770. So a very significant change in the K max value over these 3 exams. So any change in either traffic light systems, the K max value, or the topography pattern, you're going to want to refer for cross-linking, because this change can be prevented with corneal cross-linking. So that's assessment of a normal cornea, and then how you would detect progression.